on this computer. All right. So good morning. Today we will go over chapter uh, 32, 33, I'm sorry, which is the concepts for patients with vascular disease or vascular problems, in which that we will cover the concepts for the following disorders: the atherosclerosis and arteriosclerosis in hypertension, PAD, which is peripheral arterial disease, and peripheral vascular venous disease. These are some of the videos that will explain the pathophysiology and the management of patients with different kinds of hypertension. This slide takes us back to the pathophysiology and the factors that influence and affects the blood pressure. And we said that the blood pressure is the cardiac output times systemic vascular resistance, which is SVR. And the SVR, always connect that SVR to the afterload, like it's the resistance in the blood vessels, which is affected mostly by the afterload. And the vascular resistance would increase if there is a vasoconstriction, and it will decrease in vasodilatation. So you would imagine that if you are going to apply this equation for patients who have vasoconstriction, like epinephrine is vasoconstrictor. So under stress, when you have lots of adrenaline is produced or secreted from the adrenal gland, then that results in vasoconstriction. And then there is an increase also of the cardiac output. So both numbers will increase in response to stress. That's why the blood pressure will go up. So it will rise or will increase in response to these changes in the cardiac output and the systemic vascular resistance. And last week, when we discussed the CHF, we went over the factors that govern or influence the cardiac output. We said preload and afterload, the contractility of the myocardium. So you have under cardiac output, you have cardiac factors, and then renal fluid volume control, which is like the RAS system, renin, angiotensin, aldosterone. Angiotensin is a vasoconstrictor that's going to result in increased blood pressure because of vasoconstriction. Aldosterone results in sodium retention and water retention and potassium excretion. The more aldosterone we have or produced due to that RAS system activation by the kidneys, that explains why the patients with end-stage disease will be hypertensive, because they have an activation of the RAS system constantly. So the aldosterone will retain sodium and excrete potassium. That's why the patient will have hyperaldosteronism. They will have hypernatremia and hypokalemia. And the more sodium retained, more fluid, and the blood pressure will rise. In the other side, we have also here another factor, which is the systemic vascular resistance. And we have two main groups of factors that will govern and affect the SVR. And I said the resistance, always think about the vasoconstriction, vasodilatation. So for example, the sympathetic nervous system activation, alpha receptors and beta receptors, that's how the beta blockers work. So these drugs, they work on the antagonizing and blocking the alpha or beta or both receptors. So it can decrease the blood pressure by eventually, because that's going, most of the antihypertensive drugs works on this principle because it's eventually going to, by blocking that, either or both receptors, alpha or beta, and we have different types of alpha, different types of beta receptors, then the resultant effect would be vasodilatation. And also we have another humoral factor under the SVR, which is the vasoconstrictors like angiotensin and the catecholamines. And when we say catecholamines means, what do we mean by catecholamines? It's the epi and norepinephrine. That's the epinephrine and norepinephrine, so which is the adrenaline. And we have also a local regulation, which is vasodilators like the prostaglandins. They are vasodilators. The EDRF2, then endothelial. The vasoconstrictors will be the endothelin. I did explain last week under the CHF the effect of the endothelin or endothelin or endothelin and how it affects the blood pressure and the vasoconstriction. The next slide explains the cardiac output, which is very similar to what we have in the previous slide, and different details. This is also has been explained in the first one I project. So the EDRF, which is endothelial derived relaxing factor. That's the EDRF, which is believed to be one of the vasodilators. But the endothelin is the vasoconstrictor. So which means that the SVR, which is the resistance in the blood vessels, systemic vascular resistance, would increase in response to the release of too much of the endothelin. But the prostaglandins or the EDRF, they are good because they will result in vasodilatation. So this is just a quick review of the pathophysiology and the factors that govern the cardiac output and the blood pressure. And how is the blood pressure is defined as the cardiac output times systemic vascular resistance. Hypertension. So the hypertension, most of the patients you see in the hospitals, they are of the essential type, which is the primary type. And the which accounts for about 92% according to this table, but the number goes up in some textbooks to 95 and even more percent, which means that the other factors or the other etiologies like chronic renal disease, patients with end-stage renal disease, they tend to become hypertensive because of that. And also same thing, patients who have develop the end-stage renal disease, they will become hypertensive, and also patients who are hypertensive may develop the end-stage renal disease. But that will be in scenarios or cases in which that the patients are, I would say, undiagnosed, never been diagnosed. For those patients who never go to for annual checkups or never went to their healthcare provider for long periods of time, years and years, and they will eventually be diagnosed with end-stage renal disease, and then because they've been hypertensive. So hypertension and renal dysfunction, it goes both ways. Hypertensive patients, they will become I mean, they may develop the renal dysfunction, or renal dysfunction will lead to hypertension. So the renal disease account for, according to this table, for about 4%. This is just rough numbers according even to the old version of the mid-surge textbook. But I don't have the the accurate current percentages, but I just roughly can say that the majority of the cases, or the patients with hypertension, they are of a primary essential type. Other etiologies would be kidney problems or renovascular disease like renal artery stenosis, RAS. That's one of the significant factors that should be considered, and especially in children. So any children or adolescent, adolescence, period, they then should consider the RAS, which is renal artery stenosis, because that stenosis of the artery could be the reason why the patient is, became hypertensive. So they do the ultrasound to make sure that there is so they can rule out the RAS. That will be the first thing they might be requesting for children who have an elevated blood pressure on more than one occasion or one reading. Oral contraceptives, another cause of hypertension. Aldosterone, like patients with primary aldosteronism. Cushing syndrome, like from the steroids. Lots of steroids are produced by the adrenal gland. Pheochromocytoma, which is one of the diagnoses we will cover in adult health 3, which is like tumor at the top of the adrenal gland, at the top of the kidney, the gland on the top of the kidney. If there's a tumor, that will lead to a disease called pheochromocytoma. Sleep apnea, thyroid, parathyroid disease. So we have too many factors that may precipitate the hypertension. So we have a primary hypertension, and we have all the following, all these factors, or these etiologies, they belong to the secondary hypertension, like kidney problems or renal artery stenosis, or the oral contraceptives. All of these are coarctation of the aorta, which is, you'll see that in children and peds. So all of these are secondary hypertension. Kidney problems and aldosterone and pheochromocytoma, Cushing syndrome. Medications, as I said, like estrogen, progesterone, which is the oral contraceptives, mostly estrogen, which elevates the blood pressure. Steroids, patients on steroids, they may also eventually have a high blood pressure. So these are the two different mean times, primary versus secondary hypertension. And so how would you define hypertension? Is it from just one occasion that took the blood pressure for for an individual or person and said that your blood pressure is higher than, if that's the norm, is 120/80, then your blood pressure is 135/85. So that's you are hypertensive patient. It's not diagnosis of hypertension. It's systemic, which means it should be according to the following steps. First of all, we have to identify the factors. We have to identify the factors that may have precipitated the high blood pressure: stress, drugs, medications, drug abuse, or any other factors. Second is that we will take the blood pressure on more than one occasion, and we have to control, or in other words, that we control the factors, like one reading early morning before breakfast, another reading before bedtime, or evening time. We have specific time, and we try to control some of the factors that we are able to control, so they have reliable, valid readings. So, and then it will be over at least 7 days, like a whole week, entire week. One read in the morning, one in the evening. Maybe you can add one in the midday, like in the afternoon, for like 7 days. So that will be, you can have a projector of the pattern of the blood pressure, and it's and knowing that you have tried to control all the factors that may increase or decrease the blood pressure, or may alter the blood pressure. So the unitary log of blood pressure readings over time, and you will evaluate that after that. So normal, we have a table of what is the normal blood pressure. We have the pre-hypertension, we have numbers, and reclassification of stage 1 and stage 2 hypertension. And we have the numbers here. So for persons over age 50, the systolic blood pressure is more important than the diastolic as a cardiovascular disease risk factor. Because as people age, the systolic blood pressure becomes more significant because it's a better indicator of the diastolic blood pressure for heart disease and stroke. So it's more reliable. The systolic is more reliable than diastolic for people over 50 as an indicator for heart disease and stroke. So the persons who are normal, what is called normotensive, the blood pressure is within range. People who are normotensive at the age of 55, they have a 90% lifetime risk for developing hypertension, just because of the aging process. So primary versus secondary, and I didn't include here the other types, like something called isolated systolic hypertension, malignant hypertension. So the primary, we went over that. We said there is no identifiable cause or etiology for the essential or primary. It could be familial, genetic. We didn't have a specific explanation why the patient had developed the, primary or essential hypertension. And we said that over 90% of cases will be of this type. Of all hypertensive cases will be of the essential primary type. These are some of the contributing factors, which may include the high sodium diet sometimes, or intake. Sometimes people just have the habit of, putting salt before even tasting the food, right? So that's kind of in the habits. We start putting the salt before even we taste the food. Is it salty or not salty? So that's one of the major, I would say, one of the major factors that would contribute to the increased and sustained increase of blood pressure or essential hypertension. Because over time, if you keep doing the same habit, that would result in essential hypertension. Excessive alcohol intake, alcohol consumption, diabetes. Patients who are diabetic, they tend to eventually, especially with uncontrolled diabetes or undiagnosed diabetes, that could result in essential or primary hypertension. Secondary hypertension, some of the contributing factors, we give examples like we said, the renal artery stenosis, kidney problems or dysfunctions, the even in OB we'll learn about the eclampsia and preeclampsia, which is the pregnancy toxicity, or what is called the eclampsia preeclampsia. And so pregnancy by itself, it can be a contributing factor for secondary hypertension. Endocrine disease, problems like endocrine-like hyperthyroidism or pheochromocytoma, aldosteronism, hyperaldosteronism, Cushing syndrome, all of these are endocrine. So I'm just reviewing what I've just said earlier. In addition to the contraceptives, which is mostly estrogen, and other drugs like the steroids. So isolated. So what's the isolated systolic hypertension? This is one of the major health problems or threats to, especially for older adults. And it is defined, we can define it as the systolic blood pressure reading above 140 with a diastolic below 90. What does that mean? When you have a systolic over 140 and diastolic less than 90, what does this would indicate? Way high systolic and fairly low diastolic. That would make it wide, or would result in wide, or what? What would you call that? The difference between systolic and diastolic.
Pulse pressure?
Right. So that is, this is one of the indicators in cardiovascular disease. Especially when we discuss in adult health 3, the valvular heart disease like mitral stenosis, aortic stenosis, regurgitation, prolapse, all these valve problems, you run into scenarios to even diagnose or at least assist in diagnosing these valvular heart disease from the pulse pressure. It's a very important indicator or of the or parameter in cardiovascular disease. So which is the pulse pressure. So so for a long time and for many years, the emphasis was placed on the diastolic reading, diastolic blood pressure, and attempts were made to lower this number to under 80. So, however, we found that as people age, or as people age, that the systolic blood pressure become more significant because it is a better indicator that than the diastolic for as a risk factor for heart disease and stroke. And that's what research has found, that or shown or revealed that the diastolic blood pressure rises until age of 55, and then it will start declining after 55. That's with the aging process. Whereas the systolic continue to rise after age of 55. So the isolated systolic hypertension is the most common form of hypertension in older adults. So in older adults, you always think about the ISH. Now, the malignant hypertension, which is a severe type of elevated blood pressure that rapidly progresses, severe elevation of both systolic and diastolic. And patients, and we know that the blood pressure is a silent killer because patients with the blood pressure, that's one of the challenges with hypertension, is that people do not exhibit or feel any problem or any headache or any symptoms that would necessitate or require that they have to seek medical attention. They will live normal life, no symptoms. They are asymptomatic, and that's why they, unless they go for annual checkups or regular checkups, they will find out their blood pressure is, or check their blood pressure regularly at home. Then they will be able to identify or say find out that the blood pressure is high. Otherwise, it's a silent killer. So it's if it stays, or the blood pressure stays elevated constantly, like constant elevation of blood pressure, it continues to destroy the major organs, especially kidneys, because it's going to increase the pressure within the kidney blood vessels and can destroy the blood vessels in the kidneys. Same thing in the eyes, and could also result in problems in the heart. So multi-system disease could result from ignoring or from not being diagnosed or not seeking medical attention, which is usually due to the not being consistent with the annual checkups. So the person with the malignant hypertension, they will exhibit symptoms. So a person with this malignant hypertension, they usually have symptoms such as morning headaches, blurred vision, dyspnea, and some symptoms of what is called uremia because of the kidney problems. So, and this will be revealed as an accumulation of BUN creatinine, which is usually eliminated by the kidney, in the urine, supposedly to be relieved and released in the urine, but it will be accumulated in the blood. So the patients with malignant hypertension, they would have systolic over 200 and diastolic over 150. So unless interventions occurs promptly, unless we take care of this problem immediately, a patient with malignant hypertension may experience renal failure or stroke or LV failure, which is left ventricular failure. So three major problems or complications could result from under treatment or ignoring the malignant hypertension, or patients not seeking medical attention. Once they experience these symptoms, it is serious. Headache, especially in the morning, blurred vision, dyspnea, uremia. All of these are significant to because it will result or cause or lead to complications such as renal failure, which is this would be acute, and LV failure, which is left ventricular failure, and then stroke. So,
Dr. Mickey,
yes,
what is the one that you said besides stroke and renal failure?
LV failure, which is left ventricular failure.
Thank you.
You know, pathophysiology. I believe that we went over most of these factors. It's genetic, heredity. So that's most, as we said, that the essential and primary type. It's the hypertension is strongly familial. And in most cases, it results from the interaction. We said it's multifactorial, which is the interaction of the environmental factors, genetic, demographic factors too. We talk about the water and sodium retention, and high sodium intake may actively increase or activate the number of pressure mechanisms and cause water retention, and water retained overload that would increase blood pressure, because blood pressure would increase because of overload, fluid overload, which is, or blood and plasma overload. And one of the treatments for modalities for hypertension is to decrease the overload, decrease the plasma volume by increasing diureses. That's one of the management strategies for hypertension, to decrease the fluid or plasma overload. Altered renin-angiotensin, and we talk about the RAS system, how it's developed and maintain the high blood pressure, because RAS system is like a vicious cycle. It continues, to elevate the blood pressure, and it will keep it elevated. The RAS system, renin, angiotensin, aldosterone. So angiotensin 2, vasoconstrictor, aldosterone, also problem because it will retain sodium and water. That's going to increase the blood pressure. So, and then constantly that activation will maintain the elevated blood pressure. So that's why patient has a sustained high blood pressure, unless we intervene and correct or treat it. Stress increase sympathetic nervous system activity, and we went over this about the epi and norepi and the adrenaline or catecholamines, how it will increase the heart, the heart rates, pulse, and result in vasoconstriction, and both will elevate the blood pressure. Insulin resistance and insulinemia. The high insulin concentration in the blood, it will stimulate the sympathetic nervous system activity, and it will halt or impair or preclude the nitric oxide mediated vasodilatation, because the nitric oxide is a vasodilator. That insulin, too much of insulin concentration in the blood, it will stimulate the sympathetic nervous system activity, and then it will prevent, preclude, or in other words, impair the nitric oxide mediated vasodilatation. So when you hear nitric oxide, it's always good because that's for hypertensive patients, because that's a vasodilator. And the last one is the endothelial cell dysfunction. So clinical manifestations, hypertension. We said that the patients with hypertension, they tend to be asymptomatic for the most, I mean, like, the majority of them, they are asymptomatic, no symptoms. That's why we call that hypertension as a silent killer. So when the blood pressure elevates to certain levels, patients may start to experience fatigue, reduced activity tolerance, dizziness, palpitations, maybe angina, dyspnea. These expected in certain scenarios, but you don't. I won't say that we should rely on these symptoms, because again, most patients with hypertension do not exhibit symptoms because their body can tolerate these symptoms. I'm not saying compensate, but tolerance to these symptoms. And some scenarios you'll find, hypertensive patients, they become symptomatic like lightheadedness and headache and dizziness when they become hypotensive, not hypertensive. So that's why don't rely on these signs and symptoms, because the patient the disease disease doesn't result always in symptoms in all patients.
Professor, I had a quick question.
Yes.
Can you repeat what you said about the insulin resistance?
Sure. We said that the high insulin concentration in the blood will stimulate the sympathetic nervous system activity, and eventually that will impair the nitric oxide mediated vasodilatation, because the nitric oxide is a vasodilator. So that mechanism will impair nitric oxide from being released. So we don't have enough nitric oxide to result in vasodilatation. So that will be the opposite, vasoconstriction. Because nitric oxide, anytime you hear nitric oxide and blood pressure, always it's good for blood pressure, because that will nitric oxide, it's a vasodilator. So complications, again, given the disease process and how most patients are asymptomatic, the complications affect the heart, brain, kidneys, and eyes. Heart, it will result in hypertensive heart disease, like coronary artery disease, CAD, left ventricular hypertrophy, because the left ventricle is going to work hard constantly against the resistance in the vascular system. Hypertensive means there is an increased or elevated SVR, systemic vascular resistance, too much pressure in the blood vessels. So the left ventricle has to work hard to overcome that resistance, which we last week we called that afterload. So the left ventricle eventually will compensate by become hypertrophic. So LV hypertrophy is one of the complications anticipated or we expected for undiagnosed or underdiagnosed or untreated hypertensive cases. CAD, coronary artery disease, heart failure also could result. For the brain, patient may develop stroke, CVA, TIA, transient ischemic attack. Kidneys, from the constant elevation of blood pressure, that would result in the destruction of the microvasculature or micro blood vessels in the kidneys, and that will result in something called nephrosclerosis, and eventually renal failure. And for those who work on or take care of patients in the dialysis center, the hemodialysis centers, they will attest to this. As you survey the patients, you'll find as a good number of patients who are undergo or have the hemodialysis, or they go for hemodialysis, they develop the renal failure, end-stage disease from hypertension. So nephrosclerosis and renal failure and the end-stage disease could result as a complication from untreated or undiagnosed or undiagnosed hypertension. For the eyes, same thing, that the retina could will damage, so that will result in retinal damage and ophthalmic problems and visual dysfunctions or problems.
Which one did you say for the kidneys?
Kidneys, nephrosclerosis. So the diagnostic studies, so we'll go over the health promotion and lifestyle changes, and but diagnostic studies will start with the fundoscopic examination of the eye, and that should be done annual for all patients who are hypertensive. Abdominal bruit, that is the bruit that you will hear on these, when you use the stethoscope, as the turbulence of the blood due to the presence of renal vascular disease, like renal artery stenosis or renal vascular disease. Psychosocial assessment, demographic, routine urinalysis, like they will find a positive, the presence of catecholamines in patients like pheochromocytoma. Like patients for pheochromocytoma, they'll have an adrenal gland tumor is producing too much of catecholamines, epi and norepi, and that will result in an elevation of blood pressure, for example. So that will be one of the diagnostic studies, which is that we will ask the patient to collect the urine over 24 hours. We give them a container, so that then we ask them to collect the urine over 24 hours, and then we'll send it to the lab and requesting for the metabolites of the catecholamines. We are looking at not the adrenaline, epi and norepi or adrenaline in the urine, but it's the metabolites of there are too many metabolites, byproducts of the metabolism of the catecholamines. The presence of these in the urine could help in the diagnosis of hypertension. Serum electrolytes, BUN, creatinine, GFR, which is supposed to be over 60, the GFR. Healthy kidneys supposed to have a GFR over 60. That's the cutoff number for the GFR. We know that the optimal number is 125, but as long as the kidneys is able to function at a GFR of 60 or above, it's within range. Any number below 60 has to be investigated. Serum lipid profile, and we know the association between the atherosclerosis and arteriosclerosis and the hypertension. That's one of the major risk factors. and the ECG or EKG, because it will determine the degree of cardiac involvement, especially if there is a left ventricular hypertrophy. The optional test, which is the measurement of the albumin excretion or albumin creatinine ratio, these can be investigated in addition to the previous, lab work to look at the albumin creatinine ratio. The white coats phenomena, which is, anyone knows what is white coat phenomena? Or white coat syndrome, sometimes they call it white coat syndrome.
Yeah, that's when you get like a raised reading when you go to the doctor because you're whatever reason, because I guess you're nervous.
Yes, exactly. Yes, Mara. So that's the phenomenon in which patients exhibit elevated blood pressure in clinical setting, but not in other settings, from their home or their own kind of setting. They don't experience these elevation of blood pressure, but it's just when they go to the clinical settings per se. So it can be doctor's office, can be clinic, can be ED, emergency department, the hospital setting. So that's could be, as you said, due to the anxiety some people experience during clinic visit. So the strategies to treat collaborative care, the goal is to reduce overall cardiovascular risk factors and control blood pressure. We start gradual because the treatment for the hypertension, it depends on the stage, like pre-hypertensive, stage 1, stage 2, and even in the interventions, we have to start the least intrusive means, which means that start from the lowest to the highest. We don't start like aggressive, like treatment with 3 blood pressure medications, for example. The first line of management would be, some cases, depends on the blood pressure, readings, it can be just lifestyle modifications. Other scenarios would be only diuretics, Lasix or furosemide, just in the morning, and that will be the treatment. So, and then we will follow up with monitoring the blood pressure. That is the significant factor or element of the treatment, is to continue daily, even I would say more than once, twice, 3 times a day, to measure the blood pressure and see how is the the response of the cardiovascular system to the treatment. Is it working? Is it effective? Or so we have to evaluate the effectiveness of the modality of the treatment which has been established. And the benefits of lowering the blood pressure, patients may not feel that or experience or feel it or see it or see like empirical evidence about the improvement or the benefits of improving or controlling the blood pressure. As I say, again, we said that the hypertension is a silent killer because there is no symptoms. So the benefits of lowering the blood pressure, according to research studies, they found that you can eliminate, reduce the stroke incidence by 35 up to 40%. Also, the management of, or the benefits of managing the lowering the blood pressure is, and reducing the acute MI, myocardial infarction, goes up to 20 to 25% reduction. You can reduce the heart failure. Heart failure goes up to like 50%. You can reduce it up to 50%. So these are some of the benefits of lowering the blood pressure. Now, lifestyle modifications, I added some bullets or some, elements of lifestyle modifications, complementary medicine or CAM medicine, and the nutritional therapy. The DASH, which is dietary approaches to stop hypertension, dietary approaches to stop hypertension. And that will entail specific instructions and guidelines according to the textbook. Now, the collaborative care, which in terms of pharmacologic or medications, drugs or medications for hypertension. So we said that when in pathophysiology, the sustained continuous high blood pressure or elevation of blood pressure because of the vasoconstriction. So if you reduce the systemic vascular resistance, which is the vasoconstriction, mostly due to that vasoconstriction, or high blood volume. So either the luminal blood vessel or the volume of the blood. So hypervolemia or the vasoconstriction. So once you reduce the systemic vascular resistance, then you will control the blood pressure, you lower it. So we can do that by giving diuretics or beta blockers. There are some direct vasodilators or angiotensin inhibitors or CCB, calcium channel blockers. So this figure it's a great one. It kind of summarizes all the cardiac drugs in one slide and provide you with all the different types of medications or specific medications that belong to each classification to control the blood pressure. So and also it's a great slide because that also provides you with details in terms of the site of action, whereas each of each class of these medications will work, the site of action. So the diuretics will be the first group of meds, thiazide, the most common ones, and the first line of management would be for hypertension would be thiazide diuretics. And it's appropriate for use for uncomplicated primary hypertension because it's going to reduce the blood volume and arterial resistance. So the thiazide is great as long as the patient doesn't have renal dysfunction. And then we have a high ceiling, which is loop diuretics like furosemide Lasix, and we have the potassium-sparing diuretics like the spironolactone, aldactone. The second one, which is the sympatholytics, which is the anti-adrenergic drugs, beta blockers. We have the alpha-1 blockers, alpha-beta blockers. And last lecture I mentioned, or Tuesday, I said that only 2 blood pressure medications that will block both receptors, alpha and beta, are the carvedilol and labetalol, 2 medications. We have another drugs called centrally acting alpha-1, and this one is agonist. If you refer to the pharmacology textbook, you will find that the mechanism is that the centrally acting alpha-1 agonist eventually result in vasodilatation, like clonidine, methyl-dopa. So it's centrally acting in the brain receptors. And then the last one, which is the adrenergic neuron blockers, like reserpine. And this one, you will mostly use it in the hospital setting. Then we have the calcium channel blockers, like diltiazem, Norvasc, amlodipine. And one of the major side effects from CCB is, other than the all antihypertensive drugs, the first side effect is hypotension, and you can say rebound tachycardia. But what else can be listed as a side effect, significant side effect from CCB? Calcium channel blockers. Constipation, because of the calcium influx and the blocking of the calcium influx or calcium channels in the GI tract, with the resulting constipation. So anytime you have patients or prescribe or have patients on CCB, make sure they are being prescribed or having a prescription for stool softeners. Two medications. The first one, which belong to the alpha-1 blockers, which is the doxazosin, which is the Cardura. So we have to be careful with the first dose effect, which is the orthostatic hypotension. Syncope, which is the sudden loss of consciousness, occasionally occur within 30 to 90 minutes following the initial dose. So the initial dose, we have to be very careful with the patient's response, especially the first half hour up to 90 minutes. Sometimes patients develop syncope, which is syncopal attack, which is the fainting, which is the sudden loss of consciousness. And the clonidine, which is the catapress, also that is the centrally acting alpha-1 agonist. Cardura is alpha-1 blocker, but clonidine is central acting alpha-1 agonist. So we instruct the patient that this drug results in what is called xerotomia, which is dry mouth. Xerotomia, which is dry mouth. So that's expected from the clonidine. Clonidine comes in tablets, like 0.1, very small, tiny dosage, 0.1 or 0.2 milligrams. Make sure that you know the dosages for clonidine. It doesn't come like 1 or 2 or 3 milligrams. It's 0.1, 0.2 milligrams, and comes in also in the topical application, like patches and tablets. So another thing about the clonidine is that not to discontinue the medication abruptly to prevent rebound hypertension. And change position slowly, because that could result in orthostatic hypotension. So individualized therapy, patients with comorbid conditions like renal, diabetes, we have to treat them, with what is called the individualized plan. Look at their disease process, the other like renal problems, diabetes problems, or problem, and then look at the complications. If they have developed any complications, the drugs, medications they are taking for these two things. So this is the comorbidity that they will have: hypertension, kidney problems, and maybe also diabetic as well. So that's becomes like, they are comorbid. So we have to treat patients with that, what is called the individualized care or individualized plan. So patients in special populations, which is really critical here in terms of that, we have to look also at the demographics and the descent for these patients' ethnicities. So, for example, African Americans, they patients from that descent who have type 1 diabetes and proteinuria, we should never treat them with ACE inhibitors and diuretics. They should have a different plan. Children and adolescents, or pregnancy-induced hypertension. So I'm giving you these examples. In the book, talks more extensively about these specifics in the farm and mid-search textbooks about the patients in special populations. So the pregnancy-induced hypertension, what would be the best treatment or medication to lower the blood pressure in pregnant women, for example? And that's when they develop the hypertension in response to, right? So that's pregnancy-induced hypertension. One of the medications that has lots of side effects, several side effects, but it doesn't have, because most of the blood pressure medications, they have a significant side effects on, if not on the mother, would be on the baby, or both. So the methyl dopa, like an aldomet, methyl dopa, it's a blood pressure medication. That's one of the very few antihypertensive drugs that should be taken by the pregnant woman or women who wants to become pregnant, because it doesn't cause fetal harm. So fetal harm is kind of can be prevented if the pregnant woman takes this drug to control hypertension. The contraindication for pregnant women not to take, certain medications to control hypertension. Pregnant women should not take direct renin inhibitors, which is the like the aliskiren, for example, which is one of the direct renin inhibitors, ALISKIREN, which is under the brand name Dectorna. ACE inhibitors also, ACE, like lisinopril or captopril, ARBs, angiotensin receptor blockers, like Diovan or valsartan. So these should not be taken by or prescribed for pregnant women, because that could cause fetal harm. Another medication that is the drug of choice for lowering the blood pressure in women with severe hypertension, in this case we call it preeclampsia, and that's usually it's done on the like under control, like in the healthcare setting, hospital setting. That hydralazine is one of the drug choices or the drug of choice for lowering the blood pressure in women with severe preeclampsia. So we have two drugs here. We have hydralazine and we have the methyl dopa. But methyl dopa comes in tablets too. Women can, pregnant women who have that problem can take it as a tablet form too.
Professor?
Yes.
Those two medications that you just said can help them or can cause preeclampsia?
No, I said to treat, the drug of choice.
Okay.
Of choice.
Thank you.
Yeah, so special populations, the elderly, for example. Although that all antihypertensive drugs are effective, in older adults, only beta blockers and diuretics have shown positive results in controlled trials, research to reduce morbidity and mortality in older adults. Two great classifications of drugs are good for older adults: beta blockers and diuretics. So hypertension. So the management or nursing management, the first line or the first thing you would include in the in the management of patients who are hypertensive is the self measurement of blood pressure. So they which is the home measurement of blood pressure. Patients measure their own blood pressure. So hypertensive crises, which is a severe abrupt elevation in blood pressure. So in patients with a history of hypertension to have failed to comply with medications or have been under medicated. So we said either undiagnosed or undertreated. And undiagnosed, we know, but that's why patients, they are undiagnosed for many reasons: access to care, not being, in compliance or adherent to the, the annual visits or the healthcare visits, or as I said, access to care problem with that, that insurance or distance or whatever resources, and we have the other major problem, which is under treatment or patients' compliance with the treatment, which is adherent to the regimen. But you put the patient on 2 drugs to be taken every day, and then eventually you'll find out the patient stopped taking the meds. And one of the reasons the majority of the patients will stop taking the meds, there are too many, I would say too many reasons, but the first reason is that they, as I said, the being hypertensive prior to taking the med, they are asymptomatic. And once they start taking the medications, then they will begin to experience the lightheadedness, some headache, some dizziness. And these are associated with the first weeks of the or the first week, when they start the medication, they will experience these symptoms, but it will over time, 4-6 weeks from the first day of taking the meds, that will go away. It will be resolved because that the patient's body will become tolerant to the symptoms, and patient will have no problem after that. But it's just because patients, and one of the reasons why patients will stop taking the meds is because they experience these problems once they start the blood pressure meds. In addition to other reasons, could be the price, the insurance, the access to care, but the problem with blood pressure medications is that the consistency and the compliance and adherence to the medication regimen, and measuring or taking the blood pressure at least, I would say, once a day once you start the blood pressure med. Now the symptoms here or the crises, and when we say hypertensive crises, it's the blood pressure of systolic over 240 and diastolic over 120. And definitely the patient, when they reach these numbers or blood pressure reach these numbers, then they will have severe headache, blurred vision, disoriented, and may experience the nosebleed, which is epistaxis. Other symptoms, the disorientation, that's from what is called hypertensive encephalopathy. That's why they become disoriented and altered mental status, because of the hypertensive encephalopathy. And it could result in complications like renal insufficiency or heart failure or pulmonary edema or epistaxis, as I said. Now the mean arterial pressure. So when treating the hypertensive emergencies, because the malignant or hypertensive crises, patients should be taken care on in the emergency department. So when treating hypertensive emergencies, the mean so we have to measure the mean arterial pressure. The mean arterial pressure, the MAP, is we always use it, often used instead of the systolic and diastolic. Systolic diastolic is not a good indicator of perfusion to vital organs, especially the brain. The best indicator is the MAP, which is the systolic plus 2 diastolic, and you divide that number over 3. It will give you the MAP. And we know that the MAP is supposed to be over 70. That's the normal MAP map. For good perfusion to the vital organs, especially the brain, we need at least 70. Okay, so we have some questions. What will be expected from the first question as a side effect of from taking the captopril, the ACE inhibitor?
Would it be A, dry cough?
Right. So dry cough is an adverse effect of captopril, and that result from the buildup the bradykinin, which can lead to the sometimes fatal angioedema, life-threatening angioedema. Second question.
Things like get more exercise, lower sodium in the diet,
Good.
try meditation, relaxation exercises.
Exactly. Right. Yeah. Perfect. So that's the to limit the sodium intake, so sodium restricted diet. The limit salt substitute, because salt. So remember that anytime you hear the salt substitute, it includes potassium. And ACE inhibitors, the ER, the ARBs and other, meds, they result in hyperkalemia. So the salt substitute, it's sodium and potassium. Low-fat diet, especially saturated fat and cholesterol. Limit alcohol intake. And as I said, you mentioned about the stress management techniques. The body mass index, which means obesity, weight gain, right? So that's also to be controlled. Body mass index of less than 30. That's the goal. Exercise at least 3 times a week. So these are the the lifestyle management that can be helpful. Number 3.
D, a can of tomato juice.
Okay, good. So that's a patient is being discharged. So 2 grams sodium diet. As we educate the patients about the high sodium content, canned food always constantly is going to be, with a high sodium content. And we know because the sodium is the preservative or one type of the chemicals that will preserve the, the dietary component. So can of tomato juice contains 330 milligrams of sodium. So that patient obviously needs a need for further teaching. So canned foods always have the high content of sodium. All right. Any volunteers for this question?
Yeah. Do you want me to?
Thank you. Yeah, if you can. Yes.
Is this like you just pick one, or is this you have to pick multiple?
No, this one is just one answer. Yeah, multiple choice.
I mean, does have pretty high systolic blood pressure. Might want to start him on oral hypertensive.
Hypertensive medication.
So
So yeah. So let's say that, although that this is the first time that your patient has been noted to have an elevated blood pressure reading, right? So given the family history, obesity, it's important to consider the coexistence of other cardiovascular risk factors. So his evaluation should include, among other like the things that you may consider, is the screening the patient for diabetes and hyper or dyslipidemia, along with an EKG too. So it is reasonable to ask the patient to submit like to be on strict diet, like low salt, and low fat diet, and to increase the exercise and activity, because these are lifestyle modifications we mentioned earlier, will likely result in weight loss. It will decrease blood pressure and will improve also the risk profile for cardiovascular disease. So if you will, like the person who will prescribe medications or your nurse practitioner, you should not start antihypertensive medication until further evaluation is completed. And second evaluation reading would confirm the diagnosis of hypertension, because this is the basic principle of diagnosing patients with hypertension. So given the explanation, you go with
E.
Right. You see, it's not an easy job to diagnose patients with, or to reach out to, to say that this patient is hypertensive. It's very extensive and very comprehensive process. So that's kind of, I know it's a long question, but this one explains, or the first question of that scenario explains the process of how would you diagnose patient with hypertension. Okay, second one.
Wait,
Professor?
Yes.
So the answer is E.
Yes. Yeah.
Thank you.
Yeah.
Professor, so on the second evaluation of the reading, it would be a confirmed diagnosis, or more than 2?
You meant 2 readings?
Yeah.
No, I said it's beyond just the reading. It's beyond just the blood pressure readings. I mentioned about the dyslipidemia, about the lifestyle modifications, the improvement of the risk profile for cardiovascular disease. So it's a long process until you confirm patient's diagnosis.
Okay.
You have to evaluate, you have to evaluate all the risk factors that can be controlled or have resulted in the high blood pressure to be sustained like that. It's also important to evaluate the patient for end organ damage. And that would include like, assessment of the heart, kidneys, eyes, nervous system. So again, this long process until you confirm diagnosis of patients with hypertension. Okay, second question.
I would say A. No, not A. Renal function tests. D.
We said it is when we say it is the initial evaluation of hypertension. We have something called GNC, and now it's 8. In 2000 was published in 2014. Provide like it's the Joint National Committee on Prevention, Detection, Evaluation, and Treatment of Hypertension, of high blood pressure. So if you look at the JNC8, now we have JNC8, which is published back in 2014, provide more details about this. So the initial evaluation of hypertension according to the JNC8, it indicates that it is important to evaluate the patient for end-stage damage. I mean, like end organ damage. And these organs are heart, kidney, eye, nervous system. So we have to evaluate all these organs because the hypertension eventually, when it's sustained, elevated for a long period, is going to damage internally these organs. So it has to be evaluated. So number 2, you would go with high blood pressure, kidney problems.
So it would be the renal function.
Absolutely, always. The first thing you would do, evaluate the kidneys, the effect of the high blood pressure, sustained high blood pressure on the kidneys. Because this is the first organ to be affected in addition to other organs, but the kidneys will be the first one to, the effect will be even faster than the other organs. So we can prevent renal damage or renal failure from controlling the blood pressure. And number 3,
the stage 1 hypertension.
this one, according to the classification, would be, if you go back to the classification, it will be stage 2 actually.
Stage 2.
Yeah. The numbers, it's consistent with stage 2.
Oh, was he at 160? Yeah,
162 over 90. Yeah.
Oh, all right. I thought he was at 159. Never mind.
Yeah. And then the last question, which is, so obviously your patient is non-compliant, right? So patient, despite having lost 3 pounds and increasing his activity, the blood pressure remains elevated. So the patient is compliant with the regimen, but despite that adherence to the plan or to the regimen, that the blood pressure kind of is not responding to these lifestyle modifications. So the blood pressure doesn't respond to the lifestyle modifications, then and blood sugar is 156 and the A1C is 7.5. And in patients who are patients hypertensive and diabetic, we should maintain the A1C below 7. That's the goal for hypertensive patients with diabetes is that we maintain the A1C below 7. So what's the best strategy then in this scenario, given that the lifestyle modification is not working and effective? And we have a guidelines. HR explains the guidelines in the book about prescription of the drugs, which medication should be prescribed and given in response to the stages. So this one, you will start treatment with 2 drug combination, like Lasix and metoprolol, for example, or Lasix and amlodipine. The ACE inhibitors, just to review from pharmacology, is that the ACE inhibitors should be used as the drug class or the drug of choice for diabetic patients who are hypertensive, or patients with hypertension and they have also diabetes, because the drug has shown not significant, but shown slow the progression of diabetic nephropathy. It can slow the progression of the nephropathy in diabetic patients. In addition to that, it will reduce albuminuria. So it will it will slow down the progression of the diabetic nephropathy, and it will reduce the albuminuria. So these are 2 outcomes which is positive from the use of the ACE inhibitors in patients who are hypertensive and diabetic at the same time. In other words, that we can protect the kidneys. Peripheral vascular disease, PVD. So it affects the legs much more frequently than the arms. Pathophysiology, the PAD, or we always refer to the peripheral arterial disease because that's most affected more than in terms of frequency. It's more than frequently affected than the venous system or the veins. So that's why when we see peripheral vascular disease, instantly we talk about the peripheral arterial disease. And peripheral, the PAD, peripheral arterial disease, that is the result of the systemic atherosclerosis. It's a chronic condition. It can be a partial or total arterial occlusion, obstruction. We call it sometimes lead or LEAD, which is the stands for lower extremity arterial disease. Lower extremity arterial disease, which is one of the manifestations of systemic atherosclerosis. And it is also associated with the high risk of cardiovascular morbidity and mortality, with sedentary lifestyle like functional impairment and decreased quality of life as well. So, and the lead increases the general cardiovascular risk. Now, the obstruction of the arterial system or of the lower extremities arteries, the PAD, the obstruction either it's an inflow or outflow. And the picture, the figure here, it's showing something called the ligament or inguinal ligament, the white line that go across. from the let's see, just from the lateral femoral cutaneous nerve down to the pubic area. See that inguinal ligament? So this is the what separates the inflow from the outflow. So the obstruction of the PAD, either it's called inflow or outflow, according to the arteries involved and their relationship to the inguinal ligament. So above the inguinal ligament, any artery is obstructed, like the distal end of the aorta, the internal, external iliac arteries, they are going to be considered as an inflow obstruction. Below that inguinal ligament, like femoral, popliteal, which is behind the knee, tibial, behind the tibial arteries. So that will be outflow. So what determines that inflow from outflow obstruction is the site of involvement, or the arterial obstruction. Is the artery above the inguinal ligament or below the inguinal ligament? So these are the most commonly affected arteries by the PAD: aortoiliac, femoral, popliteal, tibial, peroneal. Peroneal, we refer to it as also as a right fibular, another name for peroneal. Now the risk factors for PAD: atherosclerosis, hypertension, hyperlipidemia, diabetes, cigarette smoking. You can add to that also obesity, familial predisposition, advanced age from the arteriosclerosis, advanced age and arteriosclerosis. So a large number of people in the US are affected by this over age of 65. About 10 to 12 million people in the US, they are most of them affected by this. Yes.
Did you say anemia as well?
No. I said familial predisposition, advanced age, and we can classify the PAD. It's a chronic disease that can be classified as stage 1, 2, 3, or 4. Stage 1, asymptomatic, no symptoms. Stage 2, patient will develop claudication, which is, in this case, we'll call it intermittent claudication. Intermittent claudication, on and off. It's not constant, it's not continuous. It's called intermittent claudication, stage 2. Stage 3 is called rest pain. And then stage 4, necrosis or gangrene because of the perfusion. Whenever you say PAD, it's obstruction, stenosis, perfusion. So the classic symptoms of the PAD, intermittent claudication, which we classified as stage 2, it's called, it's derived from the word meaning to limp, claudication. The ischemic muscle ache or pain that is precipitated by constant level of exercise. So when the people keep walking or exercising, or especially walking or jogging, then they will experience that leg pain or lower extremities pain. As they rest or stop the activity or the exercise, then the pain will go away or be resolved. Then if they resume walking again, they will experience pain, and then as they stop, they will will disappear. So pain is on and off is consistent with the activity or the exercise. That's why we call it intermittent claudication. It's usually is resolved within 10 minutes or less with rest. They stop like for, jogging, walking, exercising activity. They stop for like 10 minutes or less, sometimes even 3 minutes or 5 minutes. Then that pain is going to be resolved and will go away. So the symptoms always reproducible with exercise. That's where that name came from, intermittent claudication. Another,
What's stage 3 and 4 again?
okay, stage 3 is rest pain, and 4 is necrosis or gangrene. So the patient also may experience paresthesia because of the perfusion may result in thin, shiny or taut skin, loss of hair on the lower extremities, pallor, diminished or absent pulses, especially at the pedal, peripheral pulses like pedal, popliteal, femoral, sometimes if the femoral is affected. Now, the rest pain, which is a sign of advanced disease, which is stage 3, that's where the pain would be more present in the forefoot or toes, heels. Rarely you will, patients will experience it in the calf or the ankles, but most will be the forefoot or toes. And it's usually aggravated by limb elevation, burning sensation, numbness. As they elevate the limb, it's opposite to and contrary to the venous problems. Peripheral venous disease patients will benefit or they will experience the relief of the extremity pain if they dangle or they make it dependent. I'm sorry, that makes it worse with the venous problem.
Dr. McKee, ask you a question.
Yeah.
So if you have if you have a DVT, that would cause pain in the calf, right?
Right. Yes.
Not the other way around. What you're talking about.
Yeah, that's that's venous. Yeah, that's venous.
Okay.
Yeah. Let me just, got you confused here with the elevation and dangling. So the elevation of the limb would benefit the patients with venous problems, peripheral venous disease, PVD, it's venous problem. Then they will benefit from the elevation of because they will have more blood returned. The venous return will increase, but patients with arterial, they don't benefit from the elevation. It will be worse. So it's aggravated by limb elevation and arterial here. We talk about the peripheral arterial disease. Numbness, the pain or burning sensation that will become even worse with the elevation of the limb. So remember this, PAD do not elevate because the elevation will make the symptoms more heightened and more severe. Venous problem, peripheral venous problem, elevation is good for them because that will increase venous return.
So what will make it better for patients with
Dangling the feet.
dangling? Okay.
Yes. Dependent position. We call it dependent position. So the rest pain is described by patients as a toothache that is severe enough to awaken patients at night, and that will occur from insufficient blood flow, and more severe at night time. And that's why you find patients with PAD, most of the time they are like sleep in their bedside chair, recliners, and because they will have their feet will be dependent and dangled below the heart level. So patients usually get pain relief by keeping the limb in a dependent position, which is lower than the heart level. There are few differences about the inflow and the outflow obstruction in terms of the manifestations, and I will refer that to the review it from the book. Slight differences about the inflow and the outflow manifestations. Complications of or from the PAD: atrophy of the skin underlying muscle, delayed healing, wound infection, tissue necrosis, arterial ulcers, which is common. We'll see that in the mid-surge units. Patients coming with ulcers or like lower extremities ulcers, we call it arterial ulcers. And we will differentiate now between the arterial ulcers and the venous ulcers. The arterial ulcers, they are initially arterial, are painful, develop on the toes, and often will be like the great toe or between the toes or upper aspect of the foot. And they're always present, or I mean, will be the site of the arterial ulcers will be below the malleolus. Very rare to see arterial ulcers above the malleolus, which is like above the ankle, I would say. So typically the arterial ulcers, they are small, rounded, or like, you know, round shape, punched out in terms of appearance, and they have a well-defined borders. You can tell which one is arterial, which one is venous. All of these are, and anytime you see necrotic tissue, like, you know, darkness of, you know, the tissue necrosis, that is definitely is an arterial, but the patient progressed, or I mean the wound or the disease progressed to the stage 4, necrosis. So arterial ulcers, all of these arterial ulcers, all of them below the ankle. And you might find, you know, rare conditions or scenarios, or is that, you know, the arterial ulcer will be above the ankle, but mostly would be below the malleolus, medial malleolus. Now the venous ulcer on the other side, you'll find them classically they are located above the medial malleolus. So if you look at the medial malleolus, which would be at this level, above this venous mostly, the ulcer is often quite painful, but arterial is more painful. The venous ulcer, like this one, and the previous also, all of these are venous ulcers. So the venous ulcers also, pain may be worse when the leg is in a dependent position. That's why we said venous ulcers elevate the leg, make it, you know, you can relieve the pain with elevation. If the venous ulcers is untreated, see how's the wound? It's not round. It's not. First of all, the size is huge compared to the arterial ulcers. Second is that, you know, it's the ulcer is not well defined, doesn't have well defined borders like the arterial ulcers, and it's you see a lot of drainage, too much drainage, and it's in reddish color. It's more red and hyperemic. Arterial most would be whitish with a punched out appearance. If the venous ulcer is untreated, the wound become more extensive, and that would result in a what is called infection and cellulitis. And frequent cellulitis could result in more threatening scenario, which is the amputation.
Which one's more painful?
Arterial is more painful than the venous. This is a chart comparing the arterial and versus the venous in terms of the pulses, the peripheral pulses, in terms of the capillary fill, and all the aspects of assessment to differentiate between arterial and venous ulcers. And this one provide the differences between arterial, venous, and the diabetic ulcers. Diagnoses mostly will depend on to diagnose PAD. We more heavily depend on the Doppler ultrasound, segmental blood pressures, ABI, which is ankle brachial index,
It's
which
time.
is I'm sorry. Okay, so I'll stop here, and I will see if we can maybe record the rest of the lecture. I can record the because I would like to start and finish with with the same content. So this lecture will be recorded. The rest of the lecture will be recorded and posted in Blackboard, so that when on what is that, Tuesday next week, we will start with ACS, which is acute coronary syndrome.